right? So are they big blood vessels, small blood vessels? Do they have vasomotor tone? And it's normal to have, you need some resistance in the circuit in order to maintain the pressure, right? Because think about it, right? If there's no resistance to flow, so if you just pump it out against no resistance at all, you can't really maintain any pressure.
When you have, I know this is food for birds, but when you do have a swan, you can calculate that.
Yeah, but you're not actually measuring it. So what's
No,
happening is
it'll
that you're
calculate.
taking these other numbers
Right.
and making a calculation.
Yeah, when you do
It's
it.
on a monitor.
Yeah. So,
But think about, Tom, is that all the blood after cardiac surgery, they measure it just to see if there's any resistance peripherally that's not getting back to help pump that heart, especially when you have a low cardiac output.
and it's a little bit of Goldilocks. You want some resistance, because you have to have some resistance, but you don't want too much resistance, right? Because it makes it too hard to pump against it. Okay. Now, the thing is that the body's natural systems are trying to adjust that more or less continuously, and we really can't measure it. We can affect it, right, by giving drugs and things. So one example is in sepsis or septic shock. Your ability to create that resistance is deranged. Okay. There are multiple derangements. And in the land of the mixed picture, sepsis and septic shock is actually a very nice example of a mixed picture where there's a volume problem, there's actually a cardiogenic problem, a very high percentage of myocardial dysfunction from the sepsis itself, and there's a distributed problem simultaneously. Good luck trying to affect that with one parameter. It can't be done. 20 years of following the wrong path, 3 large randomized trials that say the wrong path don't work. It can't be done, okay? So you need to be able to understand and manage all of these things simultaneously to deal with the hemodynamic derangement in a mixed picture like sepsis and septic shock. This is like gravity, there's no way around that. So we talk about systemic vascular resistance. You can't really truly measure it. You can calculate it, and you can affect it. What you want to know is how much is going on with volume, how much is going on with function, okay? And that'll help you to manipulate systemic vascular resistance. Does that make sense?
Sure.
And also to think that you could manipulate this entire system by looking at the CVP is dumb, right?
Well, I mean, I guess if your blood work comes back and shows that your end organs are not perfusing, then that's a good example of maybe the SVR is really high.
So we'll get there. So we have 2 questions on the table, right?
Okay.
One is, what's hypovolemia? The other is, how do I get to perfusion or hypoperfusion,
Okay.
right? We'll get there. This is the basis, okay? So there's, so one of the reasons I went into cardiology in the first place, right, is that this is a beautiful system, okay? I mean, this is like the ultimate design, right? Because you think about it, think about all your systems, right? Breathing, brain function, eating, right? Moving, okay? This is a unique system, okay? In that it does this 60, 70 times a minute, every hour, every day, for your entire life. And if it stops, even for, a couple of minutes, you're done. So this is an important system, right?
Destroyed.
Yeah. The cool thing about this important system is that we can figure it out, okay? Because it's logical and beautifully designed, okay? So what I'm sharing with you here is sort of how the design works so that you can manipulate or try to push it in the right direction or support it, right? When there are derangements, and the derangements are somewhat complex now. Does that make sense? So the way the system is designed is you have 2 fundamental components, right? You have pump and circulation. Pump and circulation. okay? They work together, obviously. The complexity in the pump, okay, is that it's actually two pumps. A right-sided pump and a left-sided pump. Unbelievable system in how, in terms of how this comes together to work simultaneously. So what I've done is I've taken 100 years of cardiology and distilled it down to 2 slides. So you'll forgive me if it's oversimplified, right? Okay. So the way the pump works, okay, left-sided pump, right-sided pump. The LV, the left-sided pump, left ventricle, is what I would call the main actor. So if we go back here, what is blood pressure? What's the Holy Grail?
Left ventricular end.
Left ventricular end-diastolic volume, right? Why is it the left ventricle? Because the left ventricle is the main actor. This is the juice, this is the stuff, this is the thing, okay? Without it, you're done, you're nowhere, okay? So what does it need? Well, we can't figure out what the left ventricle needs without understanding its purpose. Why is it there? Okay? The left ventricle generates your blood pressure. What is blood pressure? Filling and function. Filling and function of what? Of the left ventricle. Period. Okay? So, the left ventricle is a pressure pump. So there's some what I call medical principles, right? Basic medical principle. Form follows function, right? So the form of the left ventricle is that it's very muscular because it's got to do this 60, 70 times a minute, every hour, every day of your life, okay? It's a very special muscle. It's not like this muscle, okay? It's a completely different kind of muscle. It's totally unique, right? Doesn't exist anywhere else in the body. So it's thick, which is a lot of muscle, and the way that it works is unique, okay? And so what does it need then to generate the pressure? It needs filling, right? So filling and function, right? And we talked about this yesterday, but the amount of filling then that it needs is just the adequate amount, not too much, not too little, but you need it above a certain amount for it to be appropriately filled, to be able to pump out that stroke volume, okay? So just skip the RV for a second. So preload then is how much is the LV muscle filled? How much is the muscle stretched before it pumps? Before, load, work, right? So how much is it filled before it works? You with me? Okay. That is the end diastolic volume. And that's the reason that that's always been the Holy Grail, because this is the key determinant. No filling, no function. No filling and function, no blood pressure. No blood pressure, no perfusion. You're done, okay? So somehow the system has to maintain this continuously. Not so easy, right? Anyway, bottom line is LV is muscular, generates your pressure. You need to fill it a certain amount. That's preload. When we talk about answering the question that the clinicians might have in terms of what is volume, what is hypovolemia, okay, now we should answer that question, right? So it's not volume, or the relevant volume that we're interested in, is not the amount of volume that you have in your body, okay? It's not the amount of volume that you have in your blood vessels or in your circulatory system. There are such measures, total blood volume. There are devices that measure some of these things, right? Volume is not volume responsiveness. We'll talk about that further, okay? So when we say, what is hypovolemia, right? What we're talking about is reality, right? And what's relevant. And so the only volume that's really relevant is that volume, preload. That's what the volume discussion should be about. But a lot of times it's not. I mean, we can talk further about sort of where the confusion is, okay? We'll get to that more on the circulatory slide. So the LV is a pressure pump, you gotta fill it, it's muscular, that's what generates your stroke volume, yes? The RV is completely different, so it's on the right side of the circuit, okay? And it's not pumping against a high-pressure system, it's pumping against a low-pressure system. And its purpose and its function is different than the left side. Its purpose is not to generate blood pressure. Its purpose is to keep the volume flowing around the circuit, right? So what the RV then is more like a thin-walled sort of Napoleon's hat, right? And the way to think about its function is it's like a bellows, okay? So you know the bellows that you use for a fireplace, right? Think about how that works with air, okay? You kind of fill it up slowly, you push on it, not a lot of pressure, but it generates a lot of movement. Yes? That's what the RV is. It's a volume pump, okay? So because of form follows function, because it's a volume pump and not a pressure pump, it's very thin walled. It's kind of strange in terms of its anatomy and form and position, okay? And so another topic, that you could get into is how do you assess the RV, right? And most of the people that we're speaking with in the environment, clueless, right? And so what you have is, it's not so easy to see the RV, and by transthoracic, it's actually can be somewhat difficult because it's very anterior to the front, okay? And so to take somebody, without a lot of training and go to a course, and, slide it around or whatever, yeah, I saw the RV. Generally speaking, not so easy, okay? Well documented, the TD is a better way to look at that, okay? So LV is a pressure pump you need to fill. Volume means preload in this circumstance, okay? And the RV is a helper, volume pump, bellows, indoor. Keep it circulating around. You with me so far? Now you get into okay. So that's kind of, leading up to, all right, so what can I do about it, right? This is the way the system works. I have the pump, LV pump, I have left ventricular end diastolic volume. I have to maintain filling and function, but at the same time, I have to maintain the flow around, right, which is cardiac output. So how am I going to affect that, or work with it, or manage? So there's also some confusion in the environment that you'll get, let's say, from the cardiology side of the house, where they know a lot about hemodynamics, okay, and they know a lot about this type of work and filling and function, okay, but typically their purpose, cardiology's purpose in manipulating the system, okay, is not this sort of management over time, right, but rather more diagnostic, what's wrong with one of these components and how do I fix it, okay. So because of that, we're using cardiology principles, if you will, but for a different purpose, to try to figure out how can I affect that system to manage these mixed picture complex patients over a period of time, which is the reason for the ICU, right? There isn't any other reason to have an intensive care unit other than to support the patient's systems to prevent multiple organ failure and death, right? While your therapy has a chance to work, okay? So this is why it's important, okay, to understand the system and then manipulate it. Okay, so let's understand the system and how could we manipulate this circulation. So we now